I'm going to record, so just give me a second. Oh, it is recording. Okay, so this is Brother Wolf. This is HS 345. We're talking about case study number 6, and we have two groups this week, Group 1 and Group 2, that will discuss the same case, and we'll let Group 2 jump right into it whenever you guys are ready.
Okay, I have question number 1. If you want to go down to that, Ricky. So the question was, using the historical data as a guide, construct the pro forma profit and loss statement for the clinic's average for the month. So we took 2010, we did an average of January and February, and there is our forecasted profit and loss, and we are not going to make a profit. We're going to be in the hole about $40,000 based on those numbers, how we projected it.
Okay. Anything else on that, or can I go on to question 2? All right.
Go right ahead.
Okay. So question 2, Ricky.
There you
All
go.
right. So, thank you. So it says here, now consider the clinic situation without the new marketing program. How many additional daily visits must be generated to break even? So in order to do that, we knew that the monthly visits were at 1,350, and with that, in order to make sure that we break even, we had to add another 16.3, which we just rounded up to 17 for good measure. So that added on to up to 1,860. And part of this question, we also needed to make a break-even graph that could be included. And if you want to go down to that, Ricky. Okay, right there, showing that what the old total revenue was compared to the new total revenue with the added patients in order to break even at that point. And that would be question 2.
Okay, Ricky, can you scroll back up for just a second so they can see the numbers and how we got the 17 more patients per day? Okay.
Is that okay?
Yes, thanks. Yeah, thanks, Linda.
Yeah. So just stay on that for just a second before we move on to question 3.
And this is Donna, and I still think there's got to be an easier way to do this somehow in Excel. I just don't know how. I think it's like that goal statement, or I don't know how to make those work.
Okay, and now let's go to question 3. This is Linda. I have question 3. Question 3 was to repeat the same analysis as question 2, but assume that the new marketing program was implemented. And so we did that, and so all of these figures show the $7,000 monthly fixed cost for the advertising program in the numbers. And so if we still only have 45 patients a day that we're having now, we're losing even more money. We're losing $10,000 in a month. This is for a monthly basis. And if we can generate 10 more patients a day, then we're losing even more because we have to add another $1,000 for the semi-fixed cost of the physician fee and wages. So we're losing even more if we only get 10 more patients a day. And if we have 65 patients a day, which is 20 more than we have now, we're still losing money, although only $842 a month. But 75 patients a day seems to be a lot better, and we only have to add $16,000 for the semi-fixed provider costs. That jumps up to $27,000 if we jump up to 85 patients a day. So the 75 patients a day would be our preferred volume, but we have no control over how many people come into the walk-in clinic. In fact, the day starts and we don't even know how many people are going to show up that day. They don't have appointments. So I don't know how we would try to get to that volume. Anybody have any suggestions? But that would be a very good preferred volume. So if we were going to do the marketing campaign, we would have to make sure that we would add well over 20 patients a day, or it's not going to be worth it.
Okay.
Oh, okay. Do you want to wait? You want to?
Oh, sorry.
Scroll up just a minute, right there.
Right. Okay.
This is how we figured out. This was a break even. We needed 24 more patients a day to break even for the marketing campaign. So an additional 24 visits a day just to break even. Okay, then you can go on.
Okay. All right, so I guess I had 7. It says, suppose you just found out that the $32.15 monthly malpractice insurance charged is based on an accounting allocation scheme that divides the hospital's total annual malpractice insurance cost by the total annual number of inpatient days and outpatient visits to obtain a per episode charge. Then the per episode value is multiplied by each department's projected number of outpatient visits to obtain each department's malpractice cost allocation. Then it says, does this allocation scheme bias your break-even analysis? So at least the way we understood it, it was a pretty straightforward answer, very simple. We thought, yes, it absolutely does change our break-even analysis. I think we would just need additional volume to break even. These are, I guess, unforeseen or different or additional fees or whatever it may be, and we would just need more. We would just need more volume to break even on it.
It was additional fixed costs.
That's what it was. Yeah, additional fixed costs. I also had 8. After all the work performed thus far in the analysis, you suddenly realize that the hospital, as a for-profit corporation, must pay taxes. What impact does tax status have on your break-even analysis? Seeing that taxes are an additional cost, we're not non-profit, we are for-profit. We're not making a profit. If we're not making a profit, then taxes will not, I guess, affect the accounting break-even. But if we are making profit, then our volume, our revenue would need to increase to offset those taxes as well.
Okay, so I had number 9. Does this clinic have any value to the hospital beyond that considered by the numerical analysis just conducted? And then also, do the actions by the Baptist Hospital have any bearing on the final decision regarding the clinic? So, of course, some of the patients who walk into the clinic may or may not need inpatient services. So, therefore, it may have value for generating inpatient volume, but the walk-in clinic is not profitable on its own, especially when we consider the added malpractice and taxes that we just talked about. Hospital has in the case study that they did a group practice in the area, and they do have plans to purchase more that will affect the outlook of the patients available to come to clinic. Donna?
Everything slowed way down. So, final recommendation. I do, obviously we're not earning a profit right now, so we have a couple of options. Maybe we could increase our volume and or raise our prices. We could maybe look at our payer mix. Who's paying for our services, and do we really want to increase our workman's comp, and can we increase it enough so that it's profitable? When we got to that next break up above, where we had to pay for an additional provider, that really cut into our profit. So we really want to make sure that we're operating at peak performance. And then maybe we could negotiate better rates rather than discounts to everyone. And I was kind of talking a little bit to the group about, I work in an ambulatory clinic, and for years we lost money, but it was okay because we generated volume for surgeries and for other things, and so they were fine with us losing money. So I don't know if that would be a consideration. You know, it would just depend on, we have to look at the organization as a whole. So.
Great. And that's your last one, right?
That is correct.
Yeah, so I'm going to try to pin you down a little bit further. I mean, so let's say you guys did a great job. Your numbers are, your reasoning is solid. Let's explore kind of these variables that we don't know as much about. Because let's assume I'm the CFO and I hired you guys as a consulting group. And you just did this analysis. Or let's say you work for me. Let's say you are in the hospital and you work for me and you've done this analysis. What you got to decide. So we've got a clinic here. Am I leaving the lights on or am I turning them off? Or what are you going to recommend and why?
Okay, well, I think we should leave the lights on even though we're not making money right now. I think that walk-in clinics, especially with how healthcare is changing, are going to be vital. If our emergency room goes on diversion, then we're turning patients away. So if there are patients who are coming into the ED who could be serviced in our walk-in clinic, then we can utilize that. I think there's more to look at than just the red and the black on the paper. So, and perhaps that would have to be revisited, because if the Baptist Hospital comes in and they buy everything up, then maybe in a year or two, they'll be too competitive and they will have surpassed us. But I think if we could get our hands on that workman's comp volume, those people are kind of guaranteed, because people always hurt themselves at work. And then if we're contributing to the hospital organization overall, I think that would be justification to leave the doors open as well.
So
well, Donna, I was in looking at that workman's comp, if we're paying the extra $7,000 a month for that marketing and advertising expense, we're going to need to bring in at least 20 more, or we said 24 more visits a day to make up for that. And if we try it for a while and we're not bringing that in, I would think we would need to cut that advertising program.
Okay, I could concede that.
Yeah.
But I do think, we're growing practices, in the market that I'm in now, and, it's sad to say, but I have providers I have subspecialists that are sitting around right now. We're waiting to build those practices, but our financial team, someone much smarter than I am, they decided it was worth it to take the loss for a couple of years so that we could build our primary care base.
Yeah, so I was going to ask you about that. What's your team's recommendation about, or what's the forecast? Let's just say can we inflate ourselves to profitability? Did that come up at all in your discussions, that concept? Do you know what I mean by that?
So raise our rates?
No, you let inflation work its magic. So, in other words, sorry, go ahead.
Oh, I was just gonna say, could you explain that? That actually really interests me.
Yeah, so sometimes the cost and the reimbursement, or the revenues, as time goes on, we have a phenomenon called inflation, right? And if you can keep if you let inflation go up but you can keep your costs down, sometimes you can just allow time to work yourself into profitability.
Oh my gosh, that is so
Well,
cool.
well,
Never
then-
thought of it that way.
then
Well,
that
but
would-
I'm asking,
that would-
is that viable? I'm just throwing out the idea. Others have done it. What do you think in this case?
Well, that would mean that, if we had inflation, we would not be able to give our providers a raise to combat, inflation.
Well, so are our providers, I think we need to look at what our population is. Can we really increase by 24 visits? But then are our providers willing to go a couple years without a raise rather than being unemployed? And can we maximize things otherwhere? Can we gain efficiency somewhere and get our FTEs down somehow?
Yeah, so as I read the case, it sounded like a lot of the workers were already kind of stressed
Overworked?
to the end, right?
Yeah.
Everyone's overworked,
They
right?
were totally, overworked.
So you raise another issue up here. We either need to increase volume or raise our prices. Tell me how raising our prices will help.
Well, if we can collect more.
No, that's
prices are
my
higher.
point. That's my point. Because I can raise prices pretty easily. I can do that tomorrow.
Yeah.
Yeah.
If we can collect it, though.
Yeah,
Yeah,
that's the
that's-
question.
That's the problem.
Yeah,
That's-
if we,
What do you do with that? So how would
Yeah.
you maybe revise that? Right, because the CFO is going to say something like, "Well, yeah, we raised prices, but what have we just done to ourselves?"
it make less and less of the patients coming in because either they don't want to try to pay for it or they'll go somewhere else that may be cheaper. If we if we get rid of the discounts, that will do the same thing. We would lose patients because they now know we won't take the discounts and therefore they will go somewhere else. And we would, in other words, just shoot ourselves in the foot because we raised our prices or got rid of our discounts to try to benefit us, but in the long run, we're just hurting ourselves even more because we just lost more visits.
So your next sentence is a good one. We can look at our payer mix. Tell me when the different scenarios that payer mix might, because raising prices sometimes might work. When would it work and when wouldn't it, depending on what your payer mix is?
So if you get more of the insurance to pay more of the price and keep the patient side of it, the copay, the same, then it would be effective, but only if the provider was willing or able to do that, correct?
Well, so if you raise your prices, are your insurance companies going to just pay you more?
No,
No.
they won't.
We need to renegotiate those contracts because
There you go.
they're not paying enough if our revenue is only $40.66 per visit, but yet it says that walk-in clinics charge between $60 to $200 per visit, depending on the procedure. The $40.66 isn't very much.
Even if we went up by like $10 or $20. So we would have to look at the contracts and
So-
when the contracts came due, see if we could negotiate for a better rate.
So
Yeah,
let's assume we've got the best contract negotiating team in the city. So we've already negotiated our contracts. We used all the leverage we've got. And I'm playing the CFO here because I've been in these meetings. So the CFO says, yeah, that would be great, wouldn't it, if we could just go to our payers and say we want more money. We've negotiated as hard as we could. We're at our max. We can't really leverage that anymore. When would my payer mix, what kind of payer mix would be necessary in order for raising prices to work?
Well, we want the PPOs, or we want cash patients. Aren't very many of those. Or even the Medicare ones. We were talking about that earlier. Amongst our group, that Medicare still pays pretty good.
And if you raise prices, would Medicare pay you more?
No.
No.
So in the scenario, you touched on it, Donna, the scenario where raising prices, who's the only one you're likely to get money out of in that scenario?
The cash ones.
Yeah.
And in what kind of environment would that actually be realistic?
Not
rich
not a very.
environment.
There is no environment for that.
Well, that I'm pushing you, but I don't want to lead you too
They're
far down
advantaged
that road. There may be scenarios where you actually have that kind of clientele.
Are
Now,
you
we don't-
talking about like the area in which the clinic may be located in, like geography wise, like where?
Yes. So if it's
Okay.
Oh yeah.
if it's a more affluent area and you've made it so convenient and so good that it'll work, some people may pay that. I agree with you overall in general, and we don't have all the details here, right? I'm pushing
Exactly.
you a little bit to kind of think, and you can only make these as realistic as you can. I mean, you don't have all the information, so I'm not holding you to the fact that there's all these hypotheticals. I'm just trying to get you to think a little bit about what kind of scenarios or what kind of environment would we need to be in for some of these strategies to work and some of them not to work. And you never really know, but there are instances where if you have the right payer mix and you have the right kind of self-pay patients, raising prices might work. I'm not holding my breath. I don't think it would work in this scenario, but because you mentioned it there, I wanted to at least discuss it because it is something just to think about, and it helps illustrate kind of this whole dynamic of revenue and reimbursement. What's the difference between revenue and reimbursement?
Well, it's
in most businesses, you say, "Oh, our revenues went up 100%." That sounds pretty good, right? Because in most industries, increased revenue generally increases reimbursement, right? But in healthcare, it's not that way usually.
Yeah, in healthcare, it would depend on what your collection rate is, what your indigent write-off is, and then what your bad debt all of those pieces.
That's exactly right. Those are the key things to be thinking about. So we don't have all the answers here. I just really wanted to play all those angles and say, we have to think about all those things, and it's fine to say, look, we need more information here. But these are the kind of discussions that you end up having with the CFO, because they want firm answers, and sometimes you have to say, look, we don't know, or based off of doing this in another department, this is what happened, and that gives us some insight into what kind of payer mix we have. Or you bring up negotiating contracts. That's a great thing to bring up. I closed the door and I said we've done it already, but sometimes that door is still open and you actually can do that. So it's good to bring all that up. And I really am glad. Go ahead.
But if that's done, and if we can't negotiate better prices with the insurance company, and we want to increase the self-pay population that's coming in the door, how do we do that? How do we?
You'd have to advertise differently. Quit advertising to workman's comp and find some cash people.
Yeah, exactly, right? And or you go down that road and say, look, nice idea, but there aren't going to be these self-pay patients, these magical patients out there. They just don't exist. So we do need to focus on this workman's comp. And you say, okay, that's really what we're going to go after. And then you say, now we need to really consider this advertising program. And if you do, and then now you take a deeper dive into the advertising program, because you're banking your analysis off of whether that advertising program, marketing program is going to work, right? You're saying,
how long would you give that a chance? How long would you do that and to see? So we're not getting the 24 extra patients a day. How long are we going to keep putting out this extra money?
That's right, and that's exactly how you have to think. You have to say, okay, why don't we split the baby here, and we're going to do 3 months of this extra advertising and marketing. We think that'll give us enough time, and if not, then we're going to go back to Plan B or Plan C. I'm also very glad you guys brought up the fact that it's okay to lose a little bit of money on the books, because there's kind of these other items that aren't as tangible as you mentioned. You could be sending patients over to the hospital for a CT scan. They could become admitted. Not all of them are necessarily going to be inpatient revenue, but you could even have some outpatient revenue with certain services being provided at the hospital that you're going to send them to. So those are all great things to bring up. You guys did a nice job.
So can I ask you a personal question?
Yeah.
Do you think that walk-in clinics are going to be more important or less important?
It's a good question. I think there's just so many factors, right? So in the scenario where you put more control in the patient's hands, so and this is like eating an elephant. You got to do it one bite at a time. But there are little pockets out there where people have high deductible plans, and the patients more or less are paying attention to their money. And they might say, look, I can't go to the ER anymore. I used to go there, and I'm going to go to this clinic that's open at this time. So it depends. There are certain pockets where it does make a lot of sense. I live in an area where, quite frankly, we use it all the time. As a family, we use these clinics.
But do you know
they're
if
more
they're
convenient.
making money or not?
They're more.
But do you know if they're making money or not?
You know what? We end up doing a lot of our visits on the weekends. We take the kids to the walk-in clinic on a Saturday because there's no wait. I get it done, and it's not that much more expensive.
Nice.
So
do they charge more on the weekend?
No, these are clinics that are made for after hours. So they're not open during regular hours. They're housed in the same facility where there's like a medical practice. So you might have a family practitioner there, and then during the normal business time, and then when it hits 5:30, they have another doc come in. He's there until 10:30, and then he's there on weekends for certain hours.
I think they're awesome.
But it depends. It really does depend. It's a good question, though. Well, you guys did a great job. I am gonna have you. I'll post the recording, and I'm gonna cut it a little short here because we've got the next group that I'm a little late on. But good work. Any last-minute questions or thoughts?
No. So all we need to do is have one of us in the group send our stuff to you as our paperwork for this week.
No.
Correct?
So for the group part of it, or for the individual student part?
So we need to do both?
Yeah, well, so you'll want to submit this. You can each submit it in the...
Oh, okay.
Yeah, just take your file and submit it.
Okay, so we just each submit it then. Okay, that works.
Just because there needs to be a placeholder. I need in the grade book, the way it works is I need to have something there. And so just if you would do that, that would help. And then as a group, you want to post this. There's a group discussion board, right?
Mm-hmm.
Yep, there is.
And you're going to want to engage the class and maybe throw out some of these questions. And, I'll post the link for the recording there. But you want to kind of be in charge of that discussion a little bit. Keeping in mind that there's another group, you'll be able to see their presentation, and maybe they brought up things you didn't think of. Maybe you guys talked about things they didn't. So this initial case study kind of gets the ball rolling, and deeper learning occurs when you hear a whole nother group's take on it, and then you hear students' comments, and you're like, oh, I didn't even think of that, and this is getting into this deeper, and that's what this is all about. That's why case studies are a great way to learn. Nice.
Excellent.
And so we still have to go in individually and do questions 4, 5, and 6? Is that?
No. We just do the regular questions we have, right, Brother Wolf?
Yeah, so I'm going to go look. I don't have the numbers memorized, so let me go in. The assignment says, it's whatever the assignment says you're supposed to turn in.
Yeah, it's the questions we did.
Oh, okay. Okay, my bad. And then I guess really quickly, Brother Wolf, do you by any chance know when the tests will be graded?
Yeah, they have to be graded within a week. So I'm in the midst of doing that right now.
Oh, okay. All right. Just curious.
So if you look at the written analysis assignment in the course, it says complete questions 1, 2, 3, 7, 8, 9, and 10.
Okay.
And
Okay.
your answers must be typed up in a Word and/or Excel document and submitted.
Excellent.
Perfect.
So because you did these as a group, that's fine. You can go ahead and just submit what you guys have come up with. But you just want to make
thanks,
sure
Brother Wolf.
whatever you're submitting covers all of those questions.
Okay.
Brother Wolf, are you okay with us doing all of our problems from the book on Excel?
Yeah, either way, whatever's easier for you.
Okay, thanks.
Awesome. Okay.
All right.
Thanks so much.
Thanks, Brother Wolf.
Have a good night.
You too.
You too.
Okay.
Bye-bye.